All right, Chapter 13 is going to be vascular access and medication administration. Um, Pharmacology applies to patient assessment and management fundamental knowledge of the medications carried by advanced emergency medical technicians that may be administered to a patient during an emergency. So, medication administration is going to be kind of a newer thing with a little bit more added medications and very important medications as far as the advanced EMT. So we need to know the correct route, self-administered medication that may be out there, peer-administered medication, assist-administered medications to a patient. We need to know their name, the effects of them, indications, routes of administration, and dosages for the medications administered. So their actions, the contraindications and complications that may occur, side effects, and interactions with others. So it is important to understand how a medication will affect the body. So don't have the as you go through this class, you won't. I like for my students to understand why they're given medication. Not just because it's routine and this is what we do, but try to understand what it's doing on the body itself. So its mechanism of action, the indications as far as signs and symptoms, what the patient's presenting, some complete contraindications to some medications, the routes of administration you can give medications, their dose, adverse reactions, and what to do in the event of an adverse reaction. So the first rule in medicine is first try to do no harm. Ensure that a particular medication is clearly indicated for to treat the patient's condition. So make sure that you got that right medication, you got the right signs and symptoms. Those 10 R's to medication administration we learned about in the last chapter. So a careful assessment of the patient will help ensure that only beneficial medications are administered. You're going to have to assess your patients. And some patients will give you complicated signs, and you have to dig deeper to make sure that's exactly what's going on. Medical problems, alter the established balance among the systems of the body. So fully assess the patient's condition, identify and treat life-threatening injuries and illnesses that alter homeostasis. So basic math for pharmacology, it is important to calculate the appropriate medication dose. Drug doses and flow rate calculations are common areas of confusion. Adverse reactions, including death, may occur if you administer an inappropriate dose or drug. You give a medication by the wrong route, or you give the medication too rapidly or too slowly. So adverse reactions can happen from a lot of different things. So you're supposed to give a medication over 2 minutes, and you slam it in there. You may have an adverse reaction. You don't give enough of the medication. You don't give the right appropriate dose, and you're wondering why your patient isn't getting any better. And then you try to recalculate, you may give too much of it. So we have to be very careful when we're doing the math part of it. All right. Medication administration is governed by local protocol and online medical direction. So your local medical director will establish the drugs and dosages that you will give. So most EMS services carry drug boxes with a variety of cardiac medications, pain medications, anticonvulsants, antiemetics, and some other medications specific to this service. So It really is going to depend on your department's policies, procedures, on what you carry it and how you carry it. A lot of places now carry, an advanced EMT bag level that has medications up to the advanced EMT level that they can carry and administer. Um, so you may have like a drug bag inside of a carry out bag that your bag that you carry actually into the residence or onto the scene itself. Standing orders may allow medications to be administered before contacting the physician. Local policy procedures are designed to guide you in specific situations. So these are the 10 rights of medication administration. Put those into mind and make sure you try to memorize them. So right patient, right medicine, right dose, right route, right time. Make sure you're documenting, maintaining, and reporting. When you do patient care, you turn over patient care. You got the right assessment. You got the patient's right to refuse it, evaluation, and patient education. So, your procedure for administering any medication: obtain an order for medical control if you have to, or if it's standard protocol, that's kind of obtaining your order already. Know which medications that you're carrying on your ambulance is critical to safe patient care. So, know each medication's indications, know each medication's contraindications, know the therapeutic effects, know the side effects, know the appropriate dose, know when you're supposed to and not supposed to administer medication. One of the easiest way to do this, and I did it when I was on the truck, and I still try to do it even now. When you pick up the medication to look on it, make sure it's in date. Think about that medication. So you got AP 1 to 10,000 in a vial. So you're going to you think about the indications. Cardiac arrest, patients with systole or PEA. All right, cardiac arrest, and the adnate we're doing CPR. It's really not a whole lot of contraindications with AP 1 to 10,000, unless they're just for some reason allergic to epinephrine itself. Therapeutic effects, hopefully we get a pulse back from the vasoconstriction that is caused. Side effects are usually minimum unless they break out for some reason. Appropriate dosage is 1 milligram for adults and 0.1 to 0.3 mg per kg for pediatrics. All right, make sure your medical control understands the situation. Decisions you should consider is the patient's age, weight, clinical status, allergy history, comorbid. I call it comorbidity, as far as medical problems they may or may not have, and other drugs he or she may be taking. It's critical that you obtain and communicate complete, accurate information about the patient to the physician. So in this talk, a lot about online medical direction if you have to call to get permission to give a medication. You need to have that whole assessment done before you call and get that. All right, make sure you understand the physician's order. Inquire about allergy. Repeat the orders back to the physician word for word for verification. Verify the proper medication and prescription. Make the concentration print on the label before you actually give it, so that you're giving that right dose. Read the drug label at least 3 times before administering to ensure you have the right drug, especially when it's still in the box that it came in. When you prepare for the administration of the drug and before actually administering the drug. So verify the form, dose, and route of the medication that you're going to give. check the expiration date and condition of the medication, and confirm medication compatibility. So basically, you just want to make sure that you're giving the right drug, right dose, at the right time, the right indication. All right, dispose of any syringes and needles safely. Most time you're gonna have either a sharps container or portable, in your carrying bag, or you should have one on a big one on the back of your ambulance. Sometimes they're built into the ambulances also. So monitor the patient for possible adverse side effects, and document your actions and patient's response on the patient care report. So some specific medications advanced AEMT can administer: oxygen or glucose, glucagon, dextrose 50, D50, IV fluids, 5% dextrose, some saline lactated ringers, epinephrine, meter, MDI, your albuterol, and things like that, nebulized medications, albuterol, nitroglycerin spray tablets and paste, nitrous oxide, Narcan, aspirin, and others possibly, and maybe less than this. Is a lot of it depending on your local protocol. All right. So basically, cell physiology: cells are enclosed. The cell membrane is enclosed by the cell. Compounds must move through the membrane to enter the cell. Composition of the cell membrane allows it to have selective permeability, composed of phospholipid bilayer, which is an important barrier to fluid movement and the acid-base balance. So, electrolytes are atoms that carry charges, both positive and negative. Two or more atoms bound together form a molecule. Molecules with carbon atoms are organic molecules. Molecules without carbon are called inorganic molecules. Inorganic give rise to the electrolytes when they dissociate in water into their charged compound. Electrolytes are reactive and dangerous if left to circulate in the body. So water in the body helps to stabilize the electrolyte charges so that electrolytes can be used to perform metabolic functions that are necessary to life. All right. So using metabolic functions, a cation, an electrolyte with overall positive charge. Anion is an electrolyte with overall negative charge. So sodium is the principal extracellular cation, positive. Sodium is positive as plus, negative to regulate the distribution of water throughout the body. So the major factor in adequate cellular perfusion and the major component in circulating buffer. So sodium potassium pump is helped by the presence of insulin and epinephrine. Hypokalemia is low potassium, can result in decreased skeletal muscle function. Gastral disturbances, alterations in plant function, and overstimulation of nerve cells. Hyperkalemia is high potassium, can result in hyperstimulation of neural cell transmission, resulting in cardiac arrest. This is why when we were talking about hyperkalemia earlier, I said that hyperkalemia can be a very dangerous situation. All right. Calcium, principal cation, needed for bone growth. Chloride regulates pH of the stomach. Phosphorus is an important component of the formation of adenosine triphosphate, or ATP. Calcium is cation that also needed for function of the heart muscle, nerves, cell membranes, and blood clotting. Hypocalcemia can result in overstimulating the nerve cell, resulting in skeletal muscle cramps, abdominal cramps, spasms, hypotension, and vasoconstriction. Hypercalcemia can result in decreased stimulation of nerve cells, resulting in skeletal muscle weakness, lethargy, ataxia, vasodilation, hot flush. Bicarbonate levels are related to the condition of acidosis and alkalosis in the body. Um, so chloride primarily regulates the pH of the stomach, and phosphorus formulates your HTP. ATP. So fluids found in the body are composed of dissolved elements in water. So a solvent is a fluid that does the dissolving. A solute dissolves particles contained in the solvent. So fluid and electrolyte movement. Balances across the cell membrane has two components: balances of compounds and balances of charges. So homeostasis is always trying to balance charges of each side, positive and negative. So materials flow from an area of high concentration to one of lower concentration, establishing a concentration gradient. Okay, so it goes from high to low. Compounds and charges concentrated at one side of the cell membrane will move across it to an area of lower concentration. Okay, so you got the outside, the high side on the right, moves across the plasma membrane, goes to the low side. Also remember that this is called diffusion. So this is simple diffusion, high to low. All right, filtration. The type of diffusion used in kidneys to clean blood. Water carries dissolved compounds across the cell membranes of the tubules of the kidney, where the dissolved compounds are trapped. Transport is a method used to move compounds to create or maintain an imbalance of charges. So let's talk about the sodium and potassium pump. We looked at this earlier. Cell uses sodium outside of the cell and potassium inside of the cell. Depolarization. Sodium is positive, potassium negative. Okay, so cell uses the energy to form ATP and actively transport compounds across its membrane. All right, osmosis moves water across the cell membrane. So it occurs when there's different concentration on each side of the membrane. So increases the concentration of sodium in the extracellular fluid, decreases the wall in the fluid. So water moves out of the cell to create a balance of water molecules and to dilute the increase. So you got a lot. So the water moves out to increase the size. All right. Tonicity of the solution, the effects of the osmotic pressure on the wall. Isotonic solution has the same concentration of sodium as does the cell. Okay, they're equal. Hypotonic solution has a greater concentration of sodium than does the cell. Okay, hypotonic to the left down here, so the water moves out. Hypotonic solution has a lower concentration of sodium than does the cell, so it swells up, and then the water makes it burst. So water can be intracellular or extracellular. Intracellular is within the cell, extracellular is outside the cell. So water levels in the compounds constantly shift. A homeostatic control mechanism ensure balance is restored. So vascular system functions has a fluid highway and contains cells. So it can be thought of as another fluid compartment. So exterior compartment. So intravascular water portion of the circulatory system surrounding the blood cells. Interstitial is water outside the vascular system and between surrounding cells. So interstitial fluid acts as a buffer between the other compartments. There are 3 fluid compartments in the body. Intravascular is extracellular, interstitial is extracellular, and then you got intracellular. Extracellular fluid occupies any area that is not inside the cell. So it acts as a conduit for transferring gases and nutrients between the vascular and interstitial fluid compartment. So the levels are regulated by the presence of the interstitial fluid accounts for 60% of the total body weight, occupying the microscopic space between cells. It consists of gel-type protein that helps disperse the water evenly throughout the interstitial compartment. So basically it helps move water fluid between cells in the vasculature area. Alright, perfusion occurs in the capillaries as a result of high hydrostatic pressures and osmosis in the capillary bed. Okay, interstitial fluid is within all cells of the body. Large proteins within the cell can draw fluid into the cell. So how do we balance fluid? Some form of water surrounds all cells. It plays a part in cell metabolism and maintaining homeostasis. The body adjusts change in the balance between intracellular fluid and extracellular fluid by retaining or eliminating water. So fluid levels in the body are balanced when intake and equals output. The maintenance of the internal environment of the cell is regulated by the feedback system. So let's look at dehydration. Dehydration is depletion of the body's total systemic fluid volume. More common in older adults and young children because of metabolism going and medications that could affect it. Okay? So it may take days to manifest. It could be the result of a medical condition. So like diarrhea, vomiting, hemorrhaging, insufficient fluid intake, infection. So as fluid is lost in the vascular component, the body reacts by shifting interstitial fluid into the vascular area. So it forces a shift of fluid from the intracellular to the extracellular compartment. So total systemic fluid deficit occurs. So you may see some decreased LFCs, orthostatic hypotension, dry mucous membranes, tachycardia, poor skin turgor, flush dry skin, decreased urine output. And we talked about the different causes. Overhydration is a result in total systemic fluid volume increases in the body. Okay, times fluid fills the vascular compartment, filters into the interstitial compartment, and is forced from the engorged interstitial compartment into the intracellular compartment. So the fluid basically backs up, resulting in cell death. Signs and symptoms include shortness of breath, puffy eyelids, edema, polyuria, moist crackles, rails, and the lung sounds off potatoes, acute weight gain. So, causes include unmonitored IV lines, kidney failure, and prolonged hyperventilation. So, IV fluid composition, compounds and ions dissolved in the solution are identical to the ones found in the body in your IV fluid. Okay, each solution is a concentration of solute and solvents. Sodium is used as the benchmark to calculate a solution's tonicity. So the concentration of sodium in the cells of the body is approximately 0.9%. So a common IV fluid is normal saline. Altering the concentration of sodium in the IV fluid can move the water into or out of any fluid compartment in the body. So basically, we use sodium levels found in the blood work to see what level we need to take in or not give. So crystalloid solutions dissolve crystals in water. Colloid solutions contain molecules using protein too large to pass out of capillary membranes that remain in the vascular compartment. So have a very high osmolarity. Draw fluid into the interstitial and intracellular compartments into the vascular compartment. So they do work well with reducing edema when expanding the vascular compartments. However, they could cause dramatic fluid shifts. All right, isotonic solutions, nearly the same osmolarity as serum and other body fluids. They expand the contents of the intravascular compartment without shifting fluid to or from other compartments. So fluid remains in the vascular compartment, so be careful to avoid fluid overload with isotonic solutions. Patients with hypertension and heart failure are at greatest risk of fluid overload. LR solutions is usually generally used in the field for patients who have lost large amounts of blood. D5W is a special type of isotonic solution. As long as it remains in the bag, it is considered an isotonic solution. After administration, the dextrose is quickly metabolized and the solution becomes hypotonic. So a lot of times we'll use LR with trauma patients and your OB patients. Hypotonic solutions, lower concentration of sodium in the cells, hydrate the cells while depleting the vascular compartment. It may be needed for patients on dialysis when diuretic therapy dehydrates the cells. It is dangerous to use. They can cause a sudden fluid shift in intravascular space to the cells. Hypertonic solutions, osmolarity higher than the serum, has more ion concentration than serum. Shift bodily fluids into the vascular space and pull fluid and other spots from the intracellular and interstitial compartments into the intravascular compartment. So it helps stabilize blood pressure, increase urine output, and reduce edema. So it's rarely used in a pre-hospital setting. Careful monitoring is needed to guard against fluid overload, and it should not be given to patients with diabetic ketoacidosis or others at risk of cellular dehydration. All right, technical administration, keep the IV equipment sterile. So it all should come pre-packaged. This helps in preventing any kind of infections and abnormal bacteria growth. Prepare all the equipment first. So they like the equipment includes an elastic, constricting band. Also use the called the tourniquet, antiseptic wiper solution, usually alcohol pattern or iodine gauze. Just little 2x2 most of the time come pre-packaged. Tape or adhesive bandage, appropriate size IV catheter, IV extension set, saline flush, and an IV administration set. So you want to choose the IV solution. So you want to know if the patient's condition is critical, is the patient's condition stable, does the patient need fluid replacement. Each IV bag is wrapped in a protective sterile plastic bag. Okay, and that's how it should come up packaged. You should have to take off that sterile plastic bag before you actually get to the bag with the fluid in it. All right, the bottom of each IV bag has an access point for connecting the administration step. A removable pigtail that it presents as a point of no return line protects the store access point. IV solution bags can be different fluid volumes. Still here to the very far left is 1,000. That's a 500 ml bag in the middle and a 250 to the right. It also comes in 150 ml if you need it to. So basically, you're gonna take pick what solution you need to have. Make sure it's in date. You're gonna take that sterile cover off of it, and then there's your the bottom down here has the access point. Choosing administration step, move fluid from IV bag into the patient's vascular system. So it has a piercing spike protected by a plastic cover. So you don't show it here, but it's at the top. Different sizes for different situations and patients. Most drip sets have a number visible on the package. So it indicates number of drops it takes for 1 ml of fluid to pass through the orifice and into the drip chain. So basically, there's 3 different sets that we'll carry on the truck. You have a micro drip, which is a 60 drop set per ml. Then a macro drip, which only takes 10 to 15 drops per ml. Micro is smaller, macro is bigger. These blood sets are special types of macro drip sets here, and that's what you see here. Basically, you have to run the blood components on one side and the saline on the other, so that it mixes and moves quicker through this filter set and the drop chambers here. Also, macro drips usually be what you use for your pediatric patients also with a 60 drop set. But we'll show you a little bit different drip chamber that maybe there's actually a collection point from the IV solution ports into this collection point. It actually measures it out a little bit better for you so that you don't possibly overhydrate these patients. All right, choose an IV site. It's your next guess, or next part of the procedure. So locate a vein section with the straightest appearance. Choose a vein that has a firm, round appearance or springy when palpated, and avoid areas where the vein crosses the other joint. You got many different sites here: the dorsal veins here at the top of the foot, the medium cubital, the brachial, the antecubital. We got axillary veins and subclavians up here. We don't really get into a lot of those a lot of times. Internal jugular up here, the cephalic vein, and the basilar vein of your biceps. All right, and avoid any extremity that shows signs of trauma, injury, infection, or edema due to you don't want to push that fluid out into the venous flow. Do avoid any extremity with fistula. Avoid any extremity at the same time as a prior mastectomy or lymph node dissection surgery. Also, another rule of thumb, you can use them, but we don't recommend it. Patients having stroke-like symptoms. That way, there's no possibility of throwing the thrombus also. All right, choosing an IV site. Choosing an IV site for critical patients always start in the cubital fossa or higher. That's in the middle of the anterior part of the bend of the elbow. Always try to start distally and work proximal. Stabilize the wrist and veins by flexing the wrist and pulling the skin tone over the vein. So, often large protruding arm veins can move from side to side Then cannulation causes you to miss the vein and result in possible penetration. Hold hand on the vein to place it by pulling the skin over the vein taut with the thumb of your free hand as you flex the patient's hand. If you're doing this in the hand, you can also pull with your opposite hand in the proximal part of the arm, so to try to get that vein to stabilize a little bit. Applying lateral retraction to the vein with your free hand can stabilize veins in the forearm and intercubital areas. Excuse me. So, choosing the catheter. Over the needle catheters and butterfly catheters are the most common. Catheter selection should reflect the need for administration as far as the age of the patient and the location of the site. Over the needle catheters are sized by their diameter, referred to as the gauge. Largest diameter catheter that will fit the vein you have chosen, or that will be the most appropriate comfort for the patient. So the more distal the IV site, the smaller the catheter. Over the needle catheters can be used for all adults and most children for long-term IV therapy. So newer over the needle catheters use several different methods to protect against the possibility of a contaminated stick. So usually with smaller size catheters can be used in the back of the hand area, the posterior hand area. Your bigger size, your 20s and your 18s, are usually used in the AC area at the bend of the elbow. However, I have seen larger veins, men and women with large veins in the back of the hand. It's going to be very sore if you try to do it with a large needle. However, if you need to get that full volume there, try to use it. A lot of times we do try to start very distal and try to work our way up. However, if you've got a quick need for quick therapy, don't be scared to use that AC area. All right, this next point is no matter what techniques you use, keep the bevel side of the catheter up when inserting into the needle into a vein. Okay, keep it up. Always bevel up. So maintain adequate traction on the vein during cannulation. All right, insert the catheter. Apply a constriction band above the site you have chosen. So you always apply it proximal to the site that you have chosen. Advance the catheter through the skin until the vein is pierced. All right, if blood is drawn, it must be drawn before any fluids or medications are administered. Make sure you follow your local protocols for blood to be drawn. But if you do have trouble, drawing blood, stop. Try to finish the establishing the IV line. A vacuum container connects to a catheter to assist with the blood collection. If you don't have one, you can draw blood from the IV site using a 15 to 20 ml syringe and pulling the plunge back. Label all tubes with the patient's name, date, and time. All right, tape the areas to secure the catheter and tubing and are securely anchored. Tear the tape before you start the IV administration itself. Double back the tubing to create a loop that acts as a shock absorber if the line gets pulled accidentally. So avoiding circumferential taping around any extremity. So basically try not to just wrap tape around a patient's arm if at all possible. Now, I will say this, I've had some very diaphoretic patients, some sweaty patients, and I didn't have a choice to help make sure that this site would stay secure. But talking about when doubling back, you don't want to basically leave this IV tubing out to possibly grabbed and pulled out. All right, steps to change the IV fluid bag. Do not allow the IV fluid bag to become completely empty. Change the bag approximately when there's 25 ml left in it. So it is a slow process. Stop the flood of the fluid from the depleted bag by closing the roller clamp. The reason why you don't want to let it completely drain is so you don't have air inside of those IV administration lines going straight into a vein. Okay, call an ambulance altogether. Prepare the new IV bag by removing the pigtail from the piercing spike port. Inspect the new bag of IV fluid for clarity and discoloration as well as the expiration date. Remove the piercing spike from the plated bag and insert it into the port along the new bag. Do not touch the piercing spike or the administration step. Alright, ensure the drip chamber is appropriately filled, and then open the roller clamp and adjust the fluid rate. So, discontinue the IV line. Shut off the flow of the line with the roller clamp. Gently peel the tape back towards the IV site. Stabilize the catheter while you loosen all remaining tape. And do not remove the IV tubing from the hub of the catheter. So fold a 4x4 gauze and place it over the site, holding it down. While you pull back the hub of the catheter, gently pull the catheter and the IV line from the patient's vein while applying pressure to control the bleeding. Saline lock. Maintain an active IV site without having to run fluids through the vein. Use primarily patients who don't need additional fluids but may need rapid medication delivery. So, access ports commonly used with patients who have disorders such as heart failure or pulmonary edema. Attach the end of the IV catheter and fill with approximately 10 ml of normal saline. So the saline remains in the port without entering the vein, preventing clotting. Also, on intermittent site eliminates the need to reestablish IV line each time the patient needs medication or fluid. So basically, these are there just in case you need them for later. However, if you got that edema patient or that patient that really don't need any fluid, that IV line, is not sitting there and could possibly just keep dripping, and for any kind of reason at all. All right. External jugular veins provide venous access to the external jugular veins of the neck. Tapping on the vein is placing a finger or the edge of a tongue of the pressure on the vein just above the clavicle, causing the vein to fill. All right, if the vein is difficult to find, place the patient supine or facilitate venous return. The catheter is inserted midway between the angle of the jaw and the midclavicular line in the same manner as a normal IV. Okay, these are really great, quick, large veins. If you can't find none in the extremities, you can look here and try to find these. If there is a flow problem, check IV fluid. Check your administration set, height of your IV bag. Always try to make sure it's high. Type of catheter used and constrict the vein. You want to make sure you didn't leave that constricted band proximal to your site. All right. All right. Possible complications are local IV site reactions. Many reactions require you to discontinue the administration, reestablish IV line in the opposite extremity, and document the event. Infiltration is escaping fluid into the surrounding tissue and not into the vein itself, causes a localized area of edema, discoloration. So the IV line was passed completely through the vein and out the other side, so you pretty much made two holes in the vein itself. The one you created to filtrate it, and then you went through it and you made another one. Sometimes excessive patient movement can cause it. A lot of people get scared of that pain. and they can cause that needle to go through. So the tape used to secure the area becomes loosened and dislodged. The catheter will start at an angle that is too shallow and has only entered the fascia surrounding the vein. Signs of symptoms include edema at the catheter site, continued IV flow after occlusion of the vein and above the point of the insertion. Patient complains of tightness and pain around the IV site. So to correct infiltration, discontinue administration, reestablish the IV line in the opposite extremity, or you move it proximal location on the same extremity. Apply direct pressure to the swollen area and reduce further swelling or bleeding into the tissue, and avoid wrapping tape around the extremity for direct pressure. So I always try to work these sites, and a lot of times you can help the edema large. Thrombophlebitis, okay, is inflammation of the vein, not usually seen with the emergency pre-hospital patient. Symptoms are fever, tenderness, restricting of the associated vein. Hardening of the vein can occur if the vein has been repeatedly punctured. So common causes include localized irritation and infection from non-sterile equipment, prolonged IV therapy, irritating IV solutions, and too rapid of other infusion. If awareness develops at the IV site, we're rapidly developing thrombophlebitis. Discontinue the infusion and save the equipment for later analysis. Reestablish the IV line and the other extremities with all new equipment in case there were unseen contaminants in the old equipment. So document will be on. Occlusion is partial physical blockage of the vein or catheter. If the flow is not sufficient to keep fluid moving out of the catheter tip, and if the blood enters the catheter, a clot may form and occlude the flow. Decrease in drip rate or the presence of blood in the IV tubing first sign. Common causes include a positional IV site, proximity to a valve, patient movement, and IV bag is empty and the blood pressure overcomes the flow and backs up in the line. To determine whether the IV line should be reestablished, use a syringe, saline, and add pressure to the line. Gently apply pressure to the plunger to disrupt the occlusion and reestablish the flow. If the flow is reestablished, ensure that the line is free and the rate is sufficient. And if the occlusion does not dislodge, discontinue administration and reestablish an IV line in the opposite extremity or at the proximal location in the same extremity. All right, hematoma. Pretty bad hematoma there in that picture. There's accumulation of blood in the tissues surrounding the IV site. So it results in from vein perforation or improper catheter removal that allows blood to accumulate in the surrounding tissues. So the blood can be seen rapidly pulling around the IV site, resulting in tenderness and pain. If the hematoma develops while you are attempting to insert a catheter, stop and apply direct pressure to help minimize bleeding. If a hematoma develops after successful catheter insertion, evaluate the IV flow and the hematoma. If the hematoma appears to be controlled and the flow is not affected, monitor the IV site and leave the line in place. The hematoma develops after the result of removing the IV line. Apply direct pressure with our 4x4 column. All right, nerve, tendon, and ligament damage results from improper identification of anatomic structures around the IV site. Risk increases if the IV site choice around joints. Symptoms could include severe shooting pain, numbness in the extremity. Remove the catheter immediately and select another IV site and document the event. Arterial punctures of bright red blood is quickly seen, either spurting from the catheter after the needle is withdrawn, or backing up into the IV tubing in the IV bag. Stop IV administration. Apply direct pressure onto the site with a gauze for at least 15 minutes to the bleeding control. And ladies and gentlemen, when you do an arterial puncture, you will know it immediately. That is a lot of pressure in that blood, and it's bright red. It's a whole lot brighter than the venous blood that you'll see. So you'll know it as soon as you do it. All right, systemic complications can develop from reactions and complications associated with IV insertion. Can be life-threatening. If the IV line is established in patent, do not remove it. Allergic reactions often minor, but anaphylaxis is possible. Any allergic reaction must be treated aggressively. It can be related to an individual's unexpected sensitivity to medication. Some common signs and symptoms are itching, shortness of breath, edema of face and hands, urticaria, bronchospasms, anaphylaxis. All right, air embolus, air bubble that blocks blood flow. Properly flushing the IV line will help eliminate any potential of introducing air into a patient. IV bags are designed to collapse as they are empty to help prevent the problem. Be sure to replace empty IV bags with full ones. The patient begins to experience respiratory distress with unequal breath sounds, consider the possibility of air embolus. Signs and symptoms include cyanosis, signs and symptoms of shock, loss of consciousness, respiratory arrest. Treating a patient with suspected air embolus by placing the patient on his or her left side with the head down and rapidly transport to the closest and most appropriate facility. Be prepared to assist ventilation if the patient experiences increased shortness of breath or inadequate tidal volume. Document the above. Okay, so basically you want to make sure you flush all of your tubing and your saline locks with saline before you actually introduce it into the catheter with the blood. Also, make sure that you are really careful with your drips. Drip lines, your 10 or 60 lock drip lines, make sure that all the bubbles are out of it. Sometimes this is what can cause your air embolism. All right, catheter shear occurs when part of the catheter is pinched against the needle, and the needle slices through the catheter, creating a free flowing segment. Catheter segments can travel through the circulatory system. Blockage of other vessels may result in myocardial infarction, stroke, or other problems. Can possibly end up in pulmonary circulation, causing a pulmonary embolus. Treatment will involve surgical removal of the shear tip. Catheter hubs are ready to take to aid in diagnosing this type of problem. Never rethread the catheter. So, you think you got it, but you're not really sure, and you take the needle out, and then you push it back through the catheter. No, don't want to do that. Patients who have experienced catheter shear with pulmonary artery occlusion may present with sudden dyspnea, shortness of breath, and possible diminished breath. So, treat the same way as the patient with air embolus and try to obtain an IV line and other extremity. Circulatory overload, patients with cardiac, pulmonary, and renal dysfunction. All right, vasovagal reactions. Some patients have anxiety concerning needles or the side of blood. A lot of times you want to talk to your patients about what you're fixing to do. A lot of times they'll tell you, so they're really scared of stuff. Basically, some patients will cause a vascular dilation, resulting in decreased blood pressure and patient collapse. So, signs include anxiety, diaphoresis, knowledge of a episode. Place that patient in dictated by protocol for shock management. Hypoload 2, monitor vital signs, establish an IV line in case fluid touches. So basically, you can scare a patient to having a syncope episode or even having a cardiac arrest episode. So, talk to your patients. They may bear down because of the concern, and you putting that needle into the arm, and this is going to cause them to vagal down. Catheters are available in various sizes. with 20, 22, 24, 26 gauges over the new catheters are best for insertion, depending on the size of the patient and size of the available vein. Butterfly catheters are ideal. Scalp veins are best used in young infants. So you see your 18s, your 16s, and 14s there. Also, 20 is probably the most commonly used. 18 above trauma patients, to if you can do that fluid therapy to get it back to that powerful part, that 89 systolic. 20 gauge is usually the most comfortable if you just need it for medication administration of some sort. 22 gauges and 24 for your pediatric and geriatric patients. So, IV locations, hand veins are painful but remain the location of choice for starting peripheral IV line. The younger pediatric patients have fewer choices for your IV site. Hand veins are painful. Protect the IV site after it's been established and it's critical. Use a pin light to eliminate the veins on the back of the hand. Scalp veins cannulation is often anesthetically unpleasant for both the child and the parents. When you're securing scalp veins, tape a paper cup over the side to avoid applying any direct pressure to the butterfly catheter. So, your pediatric patients, a little bit harder. Try to find those veins in the back of the hand. Forearms are usually pretty easy. Executable holds are going to be kind of difficult. But however, if you find that brachial vein, also, that could help too. All right, geriatric IV therapy. Smaller catheters may be preferable unless rapid fluid replacement is needed. Okay. Wow, sorry, we use that 20 and 22s. So some medications used by older adults have the tendency to create fragile skin and veins, and it will. Anticoagulant therapy, especially. So, use of tape can result in skin damage, so we try to use cloth tape nowadays and paper thin tape. The silk tape and other tape can actually pull the skin because it is so fragile. IV be careful when using macro drips. They may lead to edema if not monitored very closely. Fluid overloading is potentially serious in geriatric and pediatric patients, so monitor fluid administration carefully with all of these patients. Geriatric IV therapy. So, in choosing an IV site, consider the possibility of poor vein elasticity. So, those walls will have worn out, different things like that. Avoid small spidery veins that weave back and forth. They usually don't hold the catheters very well. Do not use varicose veins. They don't allow a whole lot of circulation. All right, intraosseous infusion techniques of administering fluids, blood, and blood products and medications into the intraosseous space of the proximal tibia, humeral head, or sternum. All right, long bones consist of the shaft, the ends of the girth plate, outer space compromising spongy skeletal bones of the emphasis in the medullary cavity of the diaphysis. So basically, the non-collapsible vein. IV infusion is indicated when you are unable to rapidly obtain the IV access in the critically ill or injured patient. So vascular access times and flow rates for various IV sites. You can see those in table 13-. So IV sites are in the sternum with a certain kind of IV needle. Humerus, proximal tibia, the distal tibia, are the common sites. So a lot of times we'll use the proximal tibia, and we'll talk about that. So becoming more and more familiar with the humerus also, we'll talk about that. Locate the humeral iris site, manipulate the patient's arm, and palpate the humeral head. And you'll use whatever particular IO insertion device you have. A lot of people talk about using the humeral iris site to turn the patient's arms inward, and I call it like a right angle across the chest area that usually opens up that humeral head. Identify the sternal iris site by palpating the sternal notch and using the IO device as an adhesive target. To look at the tibial iris site, palpate the tibial velocity, then palpate 2 centimeters medially. This is going to be your most common site. So basically, go across the flat shaft, or I call the runway of the tibia, 2 finger widths down, pretty much, and you'll get your tibial iris site. For the distal tibial iris site, identify the medial malleus and palpate 2 to 3 centimeters above it. Alright, several options are available for use. Manual insertion either consists of a solder, boring needle, trocar inserted through a sharpened hollow needle. You got a fast one, EGIO, bone injection guns, big, also the NIO devices. So you need to become familiar with your device that you're using, particularly in your service. If you work for several services, you want to become familiar with those also in the service you're working in. It does require specialized training and becoming familiar with the features, functionality, and clinical application. So the iron is pushed into the bone with a screw and twist to action. After the needle pops to the bone, the solid needle is removed, and the IV tubing is attached to the catheter. Alright, fast devices for designed elements allow IV placement in the sternum. So, an infusion tube, a subcutaneous portal, an introducer, a target with strain release patch, and then a protective dome. The fast one consists of a 14-gauge infusion tube and 10 stabilization needles. The fast responder is an updated device that has some devices. So to remove it with the fast device, phonograph the insertion tube and pull steady until the device is dislodged. Alright, one of the more commonly used ones is the EGIO device. It's a handheld battery-powered driver with a needle attached. Proximal distal tibia of adults and children, humeral heads in adults. There's different size needles available for the patient. So inside the needle, you ensure that at least one hash marked 5 millimeters can be seen after insertion. Use a 10 ml syringe to remove an EGIO, attach the syringe to the IO's lower lock and twist the syringe clockwise to remove the device and once with permission. Bone injection gun, spring-loaded device that is used to insert an IO needle into the proximal tibia of the adult and pediatric patient. Uses a safety lock device to upon has a stabilization device after the device has been inserted. Use the stabilization device as a removal tube and pull the device in once with motion while grasping the other removal. Only bad thing is this thing is very spring loaded. You have to be very careful with the patient, especially osteoporosis patients. because of the force that this big actually does. The NIO device is a spring-loaded device placed in the proximity of an adult patient. Humeral head is also in turn in sight, so it's neither a drill nor a battery. It's inserted by interlocking the safety cap by applying downward pressure in the dominant hand. The fingers of the other hand are used to pull the trigger, wings up to deploy the device. The device was pulled up in a rotating motion while the needle stabilizer is held against the skin. After introducing the trunk car is removed and any little lock tubing can be attached. The Fast 1 device align an adhesive turret to the patient and prepare to insert the device into the manubrium. So position yourself behind the patient's head. Place 2 hands on the Fast 1 device, align the stabilization needles from the target, and apply pressure until the infusion tube separates from the Fast 1 introduced. Alright. Attach heavy tubing to the insertion tube glue lock. So, basically all these aspirate blood and particles of the bone marrow to ensure proper placement. You would take a quick 10 cc syringe, it's empty, pull back on it till the blood bone marrow comes out. Slowly inject the IV solution to ensure proper placement of the needle. Adjust the flow rate as appropriate and place the protective on and begin using the device. Alright, so complications with proper use iron infusion is associated with a relatively low complication rate. Potential complications associated with IV therapy can occur with IV infusion. IV fluid will collect in the soft tissues. Risk of extravasation can be reduced substantially by using the proper insertion technique. Should be suspected that infusion does not run freely or if the site rapidly becomes a demon. Undetected state can result in compartment syndrome. So basically, if you see osteomyelitis, it's inflammation of the bone and multiple cause by infection. If you see a lot of edema around the site, normally won't there before you push inserted the eye, and you just got a fluid leakage. Through and through insertion occurs when eye need the patient with the bone on both sides. Suspect pulmonary embolism, the patient experience acute shortness of breath, pleuritic, chest pain, and cyanosis. Fractures can occur also if the insertion technique is too forceful or use iron needle too large for your patient's aging size. Alright, some contraindications. Fracture of bone intended for eye accumulation, osteoporosis, osteogenesis, bilateral knee replacement, and prosthetic ligament at either side. Alright. Mathematical principle using pharmacology fractions are expressed as the numerator of the denominator, or number D is down. Decimals distinguish numbers greater than 0 from numbers smaller than 0. Percentages are part of 100 and are denoted by the percent sign. Alright, decimal system based on worthless of 10. So used to measure length, volume, and weight. Millimeter is the basic unit of length. Later is the basic unit of volume. And gram is the basic unit of weight. Prefixes demonstrate the fraction of the base being used. Commonly used prefixes from smallest to largest is micro, milli, centime, kilo. The volume conversion is 1 liter equals 1,000 ml. So you have a 1,000 ml bag, you basically got 1 liter of solution. So when you convert and divide the smaller unit of volume by 1,000. So 100 milliliters divided by 1,000 is 0.1 liter. Okay. Weight conversion, when you convert liters to milliliters, multiply the amount in liters by 1,000. So 1.5 liters times 1,000 is 1,500 milliliters. All right. Weight conversion, convert a gram to a milligram, multiply the larger unit of weight by 1,000 to convert a milligram to gram, divided by 1,000. Convert pounds to kilograms. All right. Divide the patient's weight in pounds by 2.2. Or you can divide the patient's weight in pounds by 2 and subtract 10%. Okay, so basically you got a 50-pound patient. You want to divide to get from pounds to kilograms. You want to divide that by 2.2. So 50 divided by 2.2 is 22.727. Okay. Or you can basically say 50 divided by 2 is 25. 25 minus 20. 25 minus 10% is 22.5. All right. So let's say 40 divided by 2 is 20. Minus 10%, which is 2. Is 20 times minus 2 is 18. Okay, that's how you get from pounds to kilograms. Because a lot of your medication stuff is going to be from measured in kilograms. All right. Calculating drip rate. Dimensional analysis is the easiest way to calculate drip rate. Allows the comparison of seemingly unrelated items by setting up a relationship and using ratios as conversion frames. To calculate drip rate, you will need to know which administration set you're using, 10 or 20, 60, the length of time for the infusion, and the amount of the fluid. So desired dose is the amount of medication physician orders you to administer. Concentration of the medication on hand, the dose on hand. It's the total weight of medication contained in a specific volume. Okay, so you'll see you may have 30 milligrams of X medication in 100 ml of solution. All right. Concentration medication available, dose on hand, volume to be administered. So the desired dose is the amount of medication the physician orders you to administer to a patient. It may be expressed in a specific number of grams or milligrams per kilogram of body weight. Okay. Medication concentration is the total weight of the medication contained in a specific volume. So note the medications are contained in different volumes of solution. So this is your volume on hand. To administer medication, you must know the weight of the medication that is present in 1 ml. The weight per milliliter, total weight of medication plus the total volume in milliliters. All right, volume to be administered. Volume equals the desired dose, milligrams, divided by the concentration on hand. All right, weight-based medication doses based on the patient's weight in kilograms. 1 kilogram equals 2.2 pounds. All right, pediatric doses use weight-based resuscitation takes if they're available, but do not depend on them all the time. You do need to try to memorize some simple, more commonly used drugs in their dosages. Steps for administered by specific routes. Administer internal medications given through some portions of the digestive or intestinal tract. So you may have capsules, time release capsules, lozenges, pills, tablets, elixirs, and so on. So to give medications, you may use a small medicine cup, medicine dropper, a teaspoon, or a syringe, or a nipple. So take standard precautions, determine the need for the medication, obtain a history, including any drug. Follow the standard orders, contact medical control for permission if needed. Check the medication, determine the appropriate dose, if administering a pill or tablet. Ensure the patient does swallow the medications with water. Monitor the patient's condition, document medication given, route, time, and administration, and the patient response. Make sure you check the PNR. Rectal administration, if rectal administration of B50 is allowed, it should only be used with as a last resort, and the patient may be hypoglycemic, and no other route is optional. To administer a drug rectally, when inserting a suppository, use a water-soluble gel for lubrication. For medication in liquid form, nasopharyngeal airway or a small endotracheal tube can be used as the delivery route. All right, with a needleless syringe, gently push the medication through the tube. Once the medication has been delivered, remove and dispose. All right. Given through any route other than the GI tract subcutaneous. This is the parental route. AEMT, either sublingual SL, transcutaneous transdermal. All right. IV administration is the most common parental drug route. Equipped with syringes come prepackaged, color-coded packs with a needle already attached. And syringes consist of a plunger, a body or barrel, the flange, and the tip. 30 ml syringes is the most common type used, but they do come in 5 and 10 ml if you need them. Needle length may vary from 38 inch to 2 inches for standard injection. Packaging. Most commonly packaged ampule valve and pre-filled syringes. I like to try to buy our medications in pre-filled syringes, and especially the needleless system is safer. So ampules are breakable sterile glass containers designed to carry a single dose of medication. There's some more steps. These can be kind of dangerous because you have to break those in a certain way. Vials may contain single or multiple doses. So it's rubber stop plastic and it's made of plastic. You still have to have that needle to break into that rubber stopper. Pre-filled syringes designed for easy use, also single-dose disposable cartridges that use a reusable syringe. Drug reconstitution, injected sterile water from one valve to another valve. Powder medication making a solution for injection. All right, valves determine amount and dose of medication in the valve once the cover is removed. is no longer sterile. Some medications sterile and valves need to be reconstituted. So, with a valve, um, if it's a single dose valve, you'll pull up all the medications. If it's a multiple dose valve, you should only draw out the amount that's needed. All right, after the cover of the valve is removed, it's no longer a sterile site. So if you do have to give a second dose, please clean the top of the valve with alcohol before withdrawing the medication. So some medications are stored in valves need to be reconstituted, and it may come to two separate valves. To reconstitute a medication containing a active valve, squeeze the two valves together. Shake vigorously to mix the contents. All right, pre-filled syringe. All right, subcutaneous administration is given into the loose connective tissue between the dermis and the muscular layer. The volume is usually 1 ml or less, and it's performed using a 24 to 26 gauge half-inch to 1-inch needle. Common sites include the upper arm parts of the arm, the interior parts of the thigh, the abdomen. You do want to use an aseptic technique. So this is the method of cleansing and prevent contamination of the site when performing an invasive procedure. Basically, use sterilization and equipment, antiseptic, disinfectant, and we'll talk about what steps to follow. Eye injections are made by penetrating a needle through the dermis and subcutaneous layer into the muscle layer. So intramuscular IM. It does allow for a larger volume of medication other than over the subcutaneous route. However, it does have potential for nerve damage because of the depth of the. So common anatomic locations include the deltoid muscle, the rectus spinatus muscle, the gluteal muscle. Some patients usually have IM injectors, and they'll go into the this lateral muscle, so basically right there above the finger on the lateral side. All right, so sublingual administration, medications in the circulatory system much faster. There's a vast network of vessels under the tongue and in the cheek, buccal route. In order to work effectively, mucous membranes must be moist. Medications come in tablet, liquids, and spray forms. To administer the sublingual medications, you'll follow this step. So a lot of times this is going to be your non-glucose. However, the buccal route is oral glucose. Intranasal administration is through the nose. It includes a nasal spray for congestion and solution to moisten the nasal mucosa. Rapidly absorbed, providing a more rapid onset action than IM injectors. Administration is performed with a mucosal atomizer device and attached to the syringe allows you to spray select medication into the nasal mucosa. Only a few emergency medications can be given intranasally. This does include Narcan. So please follow your local protocol and consult with medical control about appropriate doses. Medication administered by inhalation route is used for many medications that treat respiratory emergencies. Most common is oxygen. However, a patient with respiratory problems will usually have a middle dose inhaler to use on a regular basis as needed. So medications administered by a middle dose inhaler can be delivered through a mouthpiece held by the patient or by a medicine for young children and patients who are unable to maintain their mouthpiece. For more severe medication, liquid bronchodilators may be aerosolized in a nebulizer for inhalation. So there may be small volume nebulizers, most commonly used method for administration of inhaled medications in the pre-hospital setting. Some of that was having designed to allow providers to administer nebulized medications to intubated patients. I'll show you some of that later. Some patients will not be able to effectively inhale beta agonist medications into the lungs via nebulizer or middle dose inhaler. In this case, use a small volume nebulizer in line with an assistive device, i.e. BBM if you have to. And there's a picture at the very top. So basically, you're just going to take a nebulizer and tube and put it in the middle. When you utilize a CPAP, most manufacturers have a nebulizer that is designed to work with theirs. Intravenous medication administration places the drug directly into the circulatory system. Fastest route of medication administration bypasses most barriers to drug absorption, and there is no room for error. Okay, you do not want to mess up on the IV administration. All right, make sure everything's right. Your 10 R's are correct. Medications are administered by direct injection with a needle and syringe into the peripheral line. All right, many services now use needleless systems, and that was to help provide protection against needle sticks. A bolus is a single dose given by IV route. Can be a small or large quantity of the drug. Some medications require initial bolus and then continuous IV infusion to maintain therapeutic level of the drug. Complication may arise when using the IV route, including local and systemic. So, always explain the procedure to the patient. Assembly needed equipment, drop the medication. Cleanse the injection port with an alcohol. Remove the protective cap if using the needleless system. Insert the needle into the port by holding it carefully. Screw the syringe onto the port. Pull back slightly on the syringe plunger and observe the flow return. Clean the port. Insert the needle in the syringe containing the flush. Flush the saline line. Place the needle in the sharp container and store any unused medication properly. And monitor the patient's condition and document this. The IV medications used for critical ill or injured children. The adults with IV access is difficult and impossible to obtain. A pressure infuser device should be used when infusing fluids for adults. Potential for compartment syndrome if fluid leaks outside the bone and into the osteofacial compartment. And that's the end of chapter 13. Medical cartridge and a syringe. So to assemble the two-part pre-filled syringe, pop the yellow caps off of the syringe at the medication cartridge. Insert the drug cartridge into the barrel of the syringe and screw them together. The glass ampule valves, basically you have to shake those, make sure that the medication is at the bottom of the barrel end. You'll see the line around where the two join together. So please take glove hands and a 2x2 and break that away from you. No drugs should come out. You actually then take a needle and withdraw the medication. Use the lock. In trauma patients, increased circulatory volume from over-aggressive resuscitation can disrupt clot formation and increase ongoing hemorrhage. This is why we say maintain that blood pressure to maintain a radial pulse. So usually 80 to 90. We don't need that high blood pressure of 130 over 70 with a trauma patient. You do that, you're depleting solid, you're depleting sodium with your hemoglobin, your red blood cells, and you don't want to do that either. This could disrupt the clot and formation also. The most common cause of circulatory overload is failure to readjust the drip rate after flushing the IV line immediately after insertion. So that's why I would say, use the saline locks if you want to. However, make sure you get that thumb wheel. And a lot of times when we're flushing the 10 glocks or 60 glock sets, we turn the thumb wheel all the way up to get that good rush of fluid down, whatever solution we're going to use. And a lot of times we forget about readjusting that. Always monitor IV bags to ensure that proper drip rate. Patient presentation includes niche and jugular vein distension and increased blood pressure. Crackles are often heard when evaluating breast sounds. Follow the IV rate to keep the vein open and raise the patient's head to ease respiratory distress if you do see those signs and symptoms. And then high flow oxygen and monitor vital signs and breathing adequacy. And also digestion. But it is the best choice of preoperative care for injured patients with bodily fluid loss. 30 milliliters of isotonic crystal oil solution is needed to replace 1 milliliter of patient blood. Boluses of 20 ml per kg should be given to maintain perfusion, but not to raise blood pressure. So basically, you just want to get your pulses up to maintain perfusion. You don't want to hike up the blood pressure if you have a patient losing a lot of bodily fluids, where they may have a 60 systolic, but to get a pulse, a radial pulse back, they may need just an 80 or 90. So, increase the blood pressure with IV solutions will dilute remain in the blood volume. So as you can tell, crystal solutions do not carry oxygen in the hemoglobin, so you don't want to dilute what blood volume you do have, that oxygen carrying capability. Also, you may increase internal bleeding by interfering with homeostasis. So you may have a bleed that we can't see. So you don't want to try to make it worse than what it is by keep pumping more fluid into